Today, we are undertaking a deep dive into the pharmacology of pain, Chapter 26, Narcotics, Narcotic Antagonists, and Anti-Migraine Agents.
Mhm.
And this isn't just, a list of drugs. This is really a look at the powerful chemistry that lets us manage or completely rewire how we feel pain.
It's a vital area.
Hmm.
And I think it's because pain itself is just so complex.
Right.
The source material defines it as not just physical, but a sensory and an emotional experience. And these compounds, they work centrally to change how the brain perceives and tolerates that whole signal.
Okay, so let's start at the very beginning. If the goal is to stop pain, we first have to understand how it even gets delivered. When you have an injury, the body releases these signaling chemicals.
Inhibins and prostaglandins.
Exactly, and they stimulate the sensory nerves. So what are the pathways rushing that signal up to the brain?
You've got two major players here, and they both send signals to the dorsal horn of the spinal cord. First are the A-delta fibers. These are small, myelinated, and they're fast conductors.
Mhm.
They transmit that immediate, sharp pain, like when you step on a tack, ouch.
That initial sharp feeling.
Yeah.
And then you have the C fibers, which are unmyelinated, so they're slower.
Much slower, and they deliver that dull, aching, persistent chronic pain sensation.
So here's where it gets really interesting for me. The body has its own defense system, the gate control theory.
Yes. The core idea here is that the transmission of those pain impulses up the spinothalamic tract can be modulated. It can be blocked at these inner neurons in the spinal cord that act like a literal gate.
So how do we close the gate? The classic example is a back rub, right?
Exactly. We have these large diameter sensory A fibers that transmit signals that aren't pain like touch or pressure or warmth.
Mm-hmm.
And if you stimulate those large fibers, like by rubbing an injury, their signal kind of gets prioritized, and it can physically block the transmission from the smaller A delta and C pain fibers.
So you're literally using touch to interrupt the pain signal. That's fascinating.
It is a physical action exploiting a hardwired neurological path.
But the gate isn't just physical, is it? It's psychological, too.
Oh, absolutely. The gate can also be closed by descending impulses from higher up in the brain. We're talking the cerebral cortex, which is thought, and the limbic system, which manages emotion.
So this is where things like culture, stress, and even the placebo effect come in.
Precisely. They activate inhibitory nerves to tamp down that pain signal before it ever reaches full perception in the brain.
So if the body's already built to do this, what are its own internal chemical keys?
Those would be our endogenous opioids, endorphins and enkephalins. They act on opioid receptors, which are all over the CNS, peripheral nerves, even the GI tract.
And they don't just control pain, right?
No, they also control really vital functions: respiration, GI secretions, and the cam receptor trigger zone, the CTZ in the brainstem, which is responsible for nausea and vomiting.
Okay, so we've looked at how the body controls its own gate now. What happens when we introduce a massive synthetic key to force that gate shut? Let's jump into the narcotic agonists.
Right. And these are mostly synthetic now, but they all carry that very real risk of physical dependence.
So when we talk about narcotics, we're really talking about how they interact with specific receptors.
The Mu-receptors are the primary target. They give us that profound pain-blocking euphoria, but, and this is a huge but, they also carry the major liabilities:
Respiratory depression.
respiratory depression, decreased GI activity, and of course dependence.
And then there are the kappa receptors.
And kappa receptors, yeah. They offer some analgesia, but they're more associated with sedation and dysphoria. So the therapeutic use for these drugs is massive: severe pain, pre-op, even as cough suppressants.
But safety is the main headline here.
It has to be. The adverse effect you have to watch for most closely is respiratory depression. It can lead to apnea and shock, and it can happen fast. That is the #1 reason these drugs are so carefully controlled.
And we can't talk about opioids today without talking about that really common GI side effect: opioid-induced constipation, OIC.
Right. And their textbook highlights two specialized antagonists that are, they're pharmacologically brilliant in how they treat it without messing up the patient's pain relief.
So what's the problem they're trying to solve?
Well, the problem is that opioids work on Mu-receptors in the gut and in the brain. So if you give a standard antagonist like naloxone, yeah, you reverse the constipation, but you also completely reverse the pain relief.
Ah, so you wipe out the good with the bad. What's the fix?
The fix is engineering what you could call a brain-proof drug. We have methylnaltrexone, which is an injection, and naloxone, which is an oral pill.
And the genius here is?
The genius is that these molecules are designed specifically not to cross the blood-brain barrier. So they block the constipation receptors in the GI tract, but never enter the CNS to steal the patient's pain relief.
That really is a phenomenal concept. Now, let's talk about some truly dangerous drug interactions, beyond the obvious risk with other CNS depressants.
Like barbiturates or phenothiazines.
Right. There's a massive risk when you mix these drugs with certain antidepressants, especially a newer agent called tapentadol.
Kapentadol is a dual-action agent, so it's hitting opioid receptors, but it's also blocking the reuptake of norepinephrine in the CNS.
And that creates a risk for what?
A huge risk for a life-threatening complication called serotonin syndrome when it's combined with other mood elevators.
And what kinds of mood elevators are we talking about here?
We're talking SSRIs, TCAs, MAOIs, even the herbal supplements, St. John's wort. You combine any of those with a dual-action opioid like tapentadol, and the serotonin levels can just spike to dangerously high levels.
So that requires extreme caution, meticulous history taking.
Absolutely.
Okay, so the prototype for the pure narcotic agonists is morphine, gold standard for moderate to severe pain, but as we said, you have to constantly monitor for things like circulatory depression and respiratory arrest. But morphine is the classic heavy hitter, and the dependence risk is real. That's why researchers designed a middle ground. The narcotic antagonists like pentazocine.
Right, these stimulate some opioid receptors while blocking others.
What's the benefit of that?
The benefit is a lower abuse potential. The downside is, well, it's twofold. First, they can cause more unpleasant psychotic-like reactions. And second, because they block some receptors, they can actually trigger an acute withdrawal syndrome if you give them to a patient who is already physically dependent on a pure narcotic.
That sounds like a pharmacological tightrope. I mean, why use it if it has those risks plus a cardiac concern?
That's a great point. Pentazocine can cause cardiac stimulation arrhythmias, hypertension. So it has to be used very carefully in patients with heart disease. It's always about balancing efficacy and risk. The patient history is everything.
Okay, now let's talk about the pure blockers. The narcotic antagonists like naloxone and naltrexone.
These are the reversal agents.
Right.
They bind really strongly to all the opioid receptors, but they don't activate them. They effectively kick the narcotic right off the receptor site.
And their main use is reversing overdose effects like respiratory depression.
Exactly. And the textbook stresses the importance of tools like an naloxone autoinjector for rapid emergency response. But the reversal, it's not gentle.
It's violent, isn't it?
It is. The acute narcotic abstinence syndrome is intense. We're talking severe nausea, vomiting, sweating, tachycardia, hypertension, anxiety. It's a storm.
And for nursing, the half-life of naloxone is key. It's what, 30 to 81 minutes?
Crucial. Absolutely crucial. Meaning the narcotic that caused the overdose might still be in the patient's system long after the naloxone is worn off. The reversal could be temporary. You need continuous monitoring and maybe repeated doses.
Okay, shifting gears completely now. Let's move to the second major class in this chapter, the anti-migraine agents.
For severe vascular headaches, yes.
So what's the physiological culprit in a migraine?
Well, migraines are severe, throbbing headaches, often just on one side. The pain is believed to be caused by arterial dilation and hyperperfusion, basically too much blood flow to the cerebral vessels.
And traditionally, the first line of defense was the ergot derivatives, like ergotamine. How do they work?
They block alpha-adrenergic and serotonin sites, which causes systemic constriction of blood vessels, decreasing that hyperperfusion.
But that word systemic, that sounds like a problem.
It is the problem.
All right.
It leads to severe adverse effects, numbness, tingling, chest pain, even MI risk. And historically, there was the risk of ergotism, a serious toxicity.
So the contraindications are strict. No ergots for patients with hypertension, PVD, or coronary artery disease.
Not at all. That toxicity really drove the search for more selective drugs, which brings us to the triptans.
Like sumatriptan, the next generation.
Exactly. They are selective serotonin receptor blockers. That selectivity means they cause vasoconstriction primarily in the cranial vessels. They're for acute attacks, not prevention.
And sumatriptan is unique, right?
It is. It's the only triptan approved for both acute migraine and cluster headaches, especially the subcutaneous route. The side effects are still related to vasoconstriction, numbness, pressure in the chest.
And there are some really important safety interactions.
Oh, definitely. You never combine triptans with ergots. And you need to remember that dangerous 2-week washout period. They must be avoided for 2 weeks after stopping an MAOI because of heightened vasoconstrictive effects.
Let's wrap up with the essential nursing insights because managing these CNS agents requires a really high level of assessment.
It does. Dosing in kids requires extreme care. For older adults, there's an increased risk of CNS, GI, and cardio effects because of slower metabolism. Safety measures like side rails are non-negotiable.
And we have to talk about the impact of culture on pain response. This isn't about stereotypes. It's about being a sensitive assessor.
Right. For instance, studies suggest some Arab Americans might need larger narcotic doses because of metabolic differences. Some African Americans may show decreased sensitivity, so just increasing the narcotic dose could lead to toxicity instead of relief.
So you might boost with another class of drug instead.
A much safer, more effective strategy. And for some first-generation Asian Americans, it might be culturally unacceptable to show strong emotion or pain. The nurse has to proactively ask about their comfort because stoicism could be masking severe pain.
So what's the core nursing role here?
It's all about monitoring and timing. You must always have a narcotic antagonist and assisted ventilation ready to go, especially with IV narcotics. Monitor respiratory status, pulse, blood pressure, constantly.
And teaching is key. Give the medicine before the pain gets severe.
Yes, you get better results with a lower total dose that way. And teach patients how to manage side effects, like having a bowel program for constipation, and to report severe symptoms like shortness of breath immediately.
So if we connect this all back to the big picture,
Well, the subjective nature of pain and the gate control theory mean that effective pain management is never just about the drug dose. It's a constant synthesis of physiology, pharmacology, and respecting the patient's full cultural and emotional context.
that's a powerful note to end on. It seems like managing pain is a battle fought on two fronts: the chemical warfare in the CNS and the psychological warfare in the cortex. Which of those fronts do you think is most often ignored in patient care? And how can you, as a health professional or just an informed citizen, start to change that? Something to consider as you move forward.